Okay. All right. So I'm unmuted now, right? So, talking about cytology, please don't be scared about cytology. Let's first start with cytopathology principles. And whenever you look at tissue or cells, you already have your cytology principles that you are employing, and I will just emphasize that now in this lecture. So what is cytology? It's a study of cells, the structure and function. So we look at the nucleus, we look at, the cytoplasm, the nuclear and cytoplasmic membranes, as well as what's in the extracellular environment. What sort of matrix do we have? Well, looking at cell size, on exams, etc., on those images, you need to use something as a yardstick, right? So you compare that to something that you have an idea what the size is, right? So something that you know what a normal cell size is, or its nucleus. You can use a red blood cell, neutrophil. I can use lymphocyte nucleus. And then in GYN cytology, we use the intermediate squamous cell nucleus as a yardstick, right? So then some of these we say, well, these are small, medium, or large, or giant cells. So when we're saying this, even for example, for small cell tumors, small cell carcinomas, even though we're calling it small, they're about 2 to almost 3 times the size of lymphocytes, right? So these are some of the main basics. All right, so what about this? Here's a tumor. It's very cellular, and what you see is the chromatin is coarsely granular. Buzzword here, salt and pepper chromatin, right? And there's not much cytoplasm. There seems to be a bit of molding going on. So this is a classic example of small cell neuroendocrine carcinoma. And so even though it's called small cell, these tumor cells would be about 2.5 size, times the size of a nucleus, of a lymphocyte nucleus. Here's a lymphocyte, and look at the small cell over here, right? And then again, this is the histology for small cell carcinoma, a lot of mitoses, high NC ratio, coarsely granular chromatin, so salt and pepper chromatin pattern, so small cell carcinoma. This, on the other hand, just by looking at this, you know that these are giant cells, right? You see lots and lots of nuclei. So this is a multinucleated giant cells here, here, and here. If I told you this was from the thyroid, aspirate, the patient has recent upper respiratory infection, tenderness, and you aspirated it, and you see this would be that dequervans thyroiditis, right? The one that's associated with viral infection. So here's a giant cell. Here's another multinucleated giant cell, and these can be seen, for example, in granulomatous infections, granulomatous diseases, sarcoidosis, could be with mycobacterial infections as well, right? So multinucleated giant cell there. And this is another multinucleated giant cell, but this is an example of a tumor giant cell. So in malignancy, notice the nuclear membrane is irregularly thickened, right? So that's something that's going on. The chromatin is irregular. You have marked pleomorphism. So that is an example of a tumor giant cell. Now, looking at, look at the cell shapes, what else do you see? Do you have mixture of cell types or not, right? So look for the cell shapes. Do you see abnormal shapes? Does this lesion appear to be monophasic, biphasic, or even triphasic? You would expect that in sort of Wilms classically. And then sometimes you have neoplasms of mixed cell types as well, right? So squamous cell carcinoma, it has this dirty clinging necrosis, dark, very, very dark nuclear chromatin, so-called India ink nuclei. And you're going to have a very abnormal shapes, as you can see, the sort of pencil-like shapes, as well as kite-shaped cells, and on a pap stain, you get this orangophilia, as you can see here. So this is an example of squamous cell carcinoma. Okay, and then sometimes you have these biphasic tumors, right? So you have two components. If this is from the breast, you can see the epithelial component, and there's a lot of the stromal component. So very cellular stroma here, right? So fibroepithelial lesions with hypercellular stroma. Then in the breast, this would be a phylloides tumor where you have these epithelial as well as the stromal component, right? So phylloides tumor would sort of give you this appearance. A salivary gland where you have a mixture of cell types. You have this fibrillary stroma, epithelial and maybe myepithelial cells here. This is the classic cytology for pleomorphic adenoma. Okay. Right, so, and then it's pleomorphic adenoma. Sometimes you can see a lot more cellularity. The stroma, you know, may be very sparse or maybe, you know, very, very abundant. It just varies. And sometimes you can have little crystalloids associated with it as well, right? So pleomorphic adenoma. Salivary gland, again, you see some cells with sort of cytoplasm with some secretion. So there's a glandular component there, and then maybe also, you know, more of a epidermoid component. So mucoepidermoid carcinoma. So you can see more than one cell type in that. Okay. Now you look at the nucleus to say, well, you know, what's the state of health of this cells? Does, you know, does it look just reactive type, or is it metaplastic, dysplastic, or is it frankly, you know, neoplastic? Is it frankly malignant or not, right? So look at this. Here you can see a lot of these nuclei with the nucleolus appears to be prominent, and at first is quite alarming, but this is very, very enlarged view. And for the most part, there is enough cytoplasm, and you can kind of walk in between these nuclei. You know, that may be a you know, a three-dimensional field. So they're kind of respecting their neighbors. So, and you've got this streaming appearance. So this is an example of reactive or reparative change, something that you may see in inflammation. Here's inflammation, prominent nucleoli, but, you know, very two-dimensional. You don't really see much overlapping. And then sort of wisps sort of coming off from the edges. This would be sort of reactive changes. Again, two-dimensional, maybe a little clustering over here, but again, sort of falling apart at the edges. This is very, very reactive changes. Here you can see an inflammatory background, and the nucleus is enlarged, right? So the nucleus appears to be enlarged, but then notice around the nucleus, there's this a little bit of a space, right? So what happens is inflammation, there's enlargement of the nucleus is reacting to this inflammation, but during fixation, it shrinks to give rise to this perinuclear halo. It's not a cavity, so this is just a halo, and that's something you see with reactive inflammatory states. GI tract, be very careful. Here's just a nice normal, you know, honeycomb appearance of glandular epithelium right next to it. It looks somewhat like that, but look how many chromocenters you have, and it's a little more jumbled up, but it's still very cohesive. So it could be severe reactive changes versus is this malignant, right? You want to see these cells falling apart, dishesion, to call it obviously malignant. Here's again some nuclear changes with inflammation. This is a pap slide, and you can see the cells here with perinuclear halo and sort of brick red appearance. That's something that you can see more with Candida infection. So here's the Candida, and then this is just reactive changes secondary to infection. Again, here we see trichomonas and leptothrics, and inflammatory background, a sort of dirty background here, and the nucleus will be enlarged. And the most prominent perinuclear halos would be with trichomonas infection, but you don't always see them, but there's a little bit of a hint over there, right, of that. Now, this is a true cavity. This is low grade. This is L-sil. You can see a very enlarged nucleus, irregular clumping, maybe a little irregularity of the membrane there. And then this is not a perinuclear halo. It's a well-defined cavity. It's very well-defined. And then there's thickening at the edge, right? This is that viral E4 effect with low-grade lesions, right? So this is just L-sil, just showing what I just showed you in cytology. Now, here, look at the nuclei. They appear to be very smudgy, right? It's not crisp, and it's not somewhat more pinkish than purple. So this is just degenerative changes, right? So it's a little bit more eosinophil. So there's degeneration going on here. And here, what you notice is the nucleus is undergoing karyorrhexis. That's another kind of degeneration where it's just splitting up into multiple pieces, right? So just degenerative changes here. Another kind of degenerative change would be pycnosis, where it just gets dark and just condenses. So you got pycnotic nuclei here. However, this cell size is kind of small, and that's too much nucleus. So even though there's pycnosis here, that appears to be dysplastic, right? Very high NC ratio going on there. Now, what about dysplasia? What are some of the clues of dysplastic nuclei? Look at this. You have a high nucleus to cytoplasmic ratio. The nuclei even touching the cytoplasm. It's just too much nucleus for cytoplasm, marked pleomorphism. Then you look at the chromatin. It's irregularly clumped. You can start seeing abnormal shapes, maybe banana, star-shaped, etc. And if you were to divide these into quadrants, the chromatin is so irregularly clumped that you don't have the same pattern in all the quadrants. The other thing is, look at the nuclear membrane. It's irregular. You can see irregular nuclear membranes as well. So definitely dysplastic over here, right? So this is dysplastic. And another thing is the nuclear membrane is irregularly thickened as well. So all these are good clues for dysplasia. If you see abnormal mitotic figures, then hey, that's definitely wrong. So it's going to be dysplasia, if not malignancy, right? So abnormal mitotic figures are another clue. Now, nucleoli, they stain red, chromosentins tend to stain blue. And then we say the nucleoli are conspicuous or prominent or macronucleoli when we comparing them, to say, well, if they're about the size of a red blood cell, they're macronucleoli. And, something like those stop-like sign-like macronucleoli you'll see, for example, in hepatocellular carcinoma, right? And then sometimes prominent and sort of conspicuous things. Now, here's something that can be a bit of a pitfall. This is a GYN PAP, and it could be from an oral scraping, esophageal scraping, or even a pap test slide. And look at these nucleoli. They're very abnormal, and they're enlarged, and they almost appear to be sort of oblong, right? And then you look at the background, there's lots of neutrophils, and these cells tend to be sort of splitting apart. This is what you would see in pemphigus. Sometimes they may say, well, this patient has a history of a blistering skin disease or been to the dermatologist. So this is pemphigus with these bullet-shaped or these oblong-shaped nucleoli. The nucleus can have inclusions in that. So this is from the thyroid and papillary thyroid carcinoma. You have these pseudo inclusions, right? Why are they called pseudo inclusions? It's the cytoplasm that's herniating between